Hello again, class. Welcome to week 2. This week we're going to cover epidemiology and statistics. Basically, epidemiology is the study of the pattern, the cause, and prevention of diseases. And we're going to talk about some of the statistics that we're going to use in order to scientifically report those characteristics or features of epidemiology. Let's begin. We're going to cover proportion, ratios, and rates. So in epidemiology, we typically deals with how many people were exposed to the disease or to the agent, how many had the disease, that's the illness occurrence, and how many got sick and how many died or got injured. And in order to report all of these statistics, the commonly used frequency measures for summarizing the data on statistics are the ratios, the proportions, and the rates. So what is proportion? Proportion is simply defined as the fraction of the total group associated with the disease or other factor. In mathematical terms, it simply means that the numerator is always part of the denominator, and proportions are commonly expressed as a percentage. Below the slide, you'll see an example that if 1,000 college students self-reported having sex without protections, and there were 3,000 total students in the report, then the proportion of sexually active students not using any protection is simply 1,000 is to 3,000, or 1,000 divided by 3,000, and that is 0.33. And since we report proportion in percentage, we multiply that by 100, and you get about 33% of college students who are self-reporting having sex without protection. Let's move on to ratio. The ratio is the number of cases divided by the non-cases, just like in proportion, but there's one big difference. The difference here is that the numerator does not have to be part of the denominator. So let's go back to our example again. If we have 1,000 college students who are sexually active and 3,000 are not, then the ratio of sexually active to non-sexually active is 1,000 divided by 3,000, or 1 is to 3, or 0.33. Which means that for every student who is sexually active, 3 students are not sexually active. So there's a very minor difference between proportion and ratio. Now, what about rate? Well, rate is defined as a measure of the frequency. It describes how an event occurs in a defined population on a very specified period of time. This is very useful when we compare what is the rate, which means what is the frequency of an event or a disease in different locations at different times or among different groups of persons. Now, the best example I think to easily illustrate rate is, let's talk about heart rate. We can differentiate the rate of the heart rate at rest, at sitting, or running. For children, for different groups of ages, such as your children ages 7 to 12 versus older adult ages 65 and older. And you can apply this basically when you are getting statistics of disease occurrences. The last one here is percentages, and so percentages simply means it's per 100. This is probably the simplest concept that you will be reporting in your statistics for epidemiology. It is very different than fraction, because fraction means something out of 100. So again, very minor differences in definition, but they certainly mean very different things. The typical use for percentages is when we are trying to emphasize what is the percentage change of an event or an illness or a morbidity or mortality. And to calculate your percentage change, the formula is very simple. You just divide the difference between the two numbers by the starting number. So the key term here is you need to remember what was your starting number. For example, an increase from 25 to 50 would be, so you divide the difference between the two numbers, so 50 minus 25 would be 25. And then you divide that by the starting number, and our starting number is 25. So 25 over 25, or there's 100% increase when we are talking about an increase from 25 to 50. Another way of putting this is a decrease from 100 to 50 would be, again, you take the difference between the two numbers, so 100 minus 50 would be 50, and then you divide that difference by the starting number, and that would be 50 divided by 50, or 100% decrease when you're saying a decrease from 100 to 50. Now let's move on to another concept in epidemiological statistics, and that is now your odds ratio and relative risk. I think you will never read any epidemiological report without talking about these two statistics of odds ratio and relative risk. So you really need to familiarize yourself with these two concepts. Now, so both odds ratio and relative risk, they actually compare the likelihood of an event between two groups, and that's the limitation of odds ratio and relative risk. You simply can do a statistical analysis between two groups. If you go beyond the two groups, there are many other statistical procedures that will be covered in other advanced statistic courses. But for this course, we're going to talk about odds ratio and relative risk. And again, the limitation is that this is only good to compare between two groups. Odds ratio and relative risk are your commonly used measures for relative probabilities. Again, this is probabilities. You're talking about a portion of a pie. In disease, probability of the disease in case control, so that's for odds ratio, and cohort studies, that's for your relative risk. So what is a cohort study, or what are cohort studies? Well, cohorts are clearly identified groups, and the researchers specified the features, the criteria to belong to this group. It is based on an extensive literature review and supported by scientific evidence that you are going to group your cases into a cohort. Persons are chosen specifically because they were or were not exposed to one or more of the risk factors. And that is basically a very important concept in cohort study. Once they are selected, they are followed over time, and that is for prospective. However, cohort studies can also be retrospective, but again, you really need to follow what were your criteria for a particular cohort, and your cohort criteria must be based on scientific evidence in order to produce a reliable and valid data. The next one we're going to talk about is the case control. So you have your cohort study in the first one where there were features or criteria of cases and you put them into one cohort. What about case control? Well, case control, I forgot to mention that in cohort studies, again, you also have exposed and non-exposed, because that is really an important concept, that it is a relative comparison between two groups, and again, you must have an exposed and non-exposed group. In cohort studies, you specify your criteria who belong to the specific cohort, and then you have your non-cohort and they are exposed or non-exposed. Now let's go back here to the present slide. It's case control studies. So case control, by its name, it really immediately tells you that there is a case and there is a control group. So these are groups. These are group studies that has been defined as having the disease or not having the disease, but the controls now are often matched with cases on key factual factors. So in case and control groups, they are compared to the frequency of past exposure to possible risk factors. Case control is a very good design of a epidemiological studies for rare diseases. Now, case control may be compared to other study designs, such as your cross-sectional, because it only gets the data at one point. And you're learning about the disease basically at that point when it existed. And so this is very much similar again to cross-sectional study. In case and control groups, you must have the case. You will have a group of cases, and you must have a group of individuals in the control group who are not exposed. And then you actually look at the key factual factors, and you must match the two groups in order to determine what is the relative risk. So odds ratio is for cohort, and then case control is for relative risk. So let's start with what is an odd ratio. Well, an odds of an event is simply the ratio of the probability that the event will not occur, that the event will occur versus that the event will not occur. In simple terms, the odds of an event can be calculated by simply dividing the number of events by the number of non-events. Very simple. If you look at the example on the lower part of the slide, you will see that if you have a sample of 100 men, and the probability of contracting HIV for men who are not using protection is 90%, and then for men who are using protection is 10%. Then the question is what is the odds of 100 men among 100 men in contracting HIV if they are not using protection? And the answer is simply 90 divided by 10, and that is 9. So they have 9 times more odds of getting the HIV virus. So that's really very high. So the odd ratio, it tells you, the researcher, how much higher is the odds of exposure is among the cases of a disease compared with the controls. And when you compare the odds of exposure to the factor of interest among cases to the odds of exposure to the factor among the control. How do we interpret odd ratio? Well, odds ratio, I'm sorry, there's a typo there. It should be letter O. An odds ratio of 1 would mean that the odds of exposure between the case and the control is the same, and therefore the exposure is not associated with the disease. However, when you have greater than 1, it means that the odds of exposure among cases is greater than the odds of exposure among the controls, and there is a risk factor for developing the disease. So when you're exposed, you will develop the disease. There are many ways in putting this into a research question, but again, the meaning when you get the result, anything above 1, that means that there's greater odds, and that is that the exposure is a risk to the development of the disease. However, if it's less than 1, so that means that the odds of exposure among the cases is lower, and there could be protection against the exposure may have a protective effect against the disease. When we look at the calculation on how we came up with odds ratio, there's a simple 2x2 table, and you have exposed for the cases, and that's A. That's cases with disease who developed the disease and had been exposed. And for the control, it's for those who have been exposed but did not develop the disease. Whereas the second row would be your non-exposed group, and then they have cases. These are the group that developed the disease but they were non-exposed. And for the non-exposed who did not develop the disease is represented by D. In order to calculate the odds of exposure for the cases, you will need number of cases with the exposure divided by the number of cases without the exposure, and that's A divided by C. And when you look at the odds of exposure for the control group, then you simply divide the number of controls with the exposure with the number of controls without the exposure, and that's B divided by D. Now that the calculation doesn't end there. You will need to continue then in order to get the odds ratio. Then you need to get what is the odds of exposure, so that is A multiplied by the D, and what is the odds of exposure, that's B multiplied by C. And then you divide your odds of exposure divided by the odds of exposure for the exposed, and the odds of exposure for the odds of exposure for the case, and the odds of exposure for the non-exposed. And so that way you will get your odds ratio. So A and D would be the odds of exposure, the odds ratio for the exposed, and then B and C would be the odds for the non-exposed, and you divide those both and you get the odds ratio for the case and the control. Now let's move on to relative risk. So the relative risk is the measure of association for a cohort study. So as I've mentioned, odds ratio is for the case and control. Now for relative risk, this is now for measuring the association for a cohort study. Remember, in a cohort study, you specify the criteria and the features of your cohort, and then you compare that with your control. And what we can get from the relative risk, the information we get from the relative risk, is how much more likely or less likely it is for people exposed to a factor to develop a disease when comparing to people who are not exposed to the specific factor. This is very good in again, the relative risk is basically you're looking at the ratio of the attack rates of the disease among the people exposed to the factor versus those who were not exposed. To calculate the attack rate, you will need first to calculate how many people were ill in a group and what is the total number of people in a group. And then when you move on to the relative risk, then you will look at what is the attack rate for exposed persons versus the attack rate for unexposed person. Again, I'm sorry, there's a typo there in the spelling for the attack. Let's move on to the relative risk. So how do we interpret relative risk? Well, similar to odds ratio, our base point would be 1, and if it's close to 1, it means the risk of the disease is similar in the exposed versus the unexposed group. Again, anything greater than 1 would mean the risk of the disease is greater in the exposed than the unexposed, and anything less than 1 would mean that the risk of the disease is less in the exposed group, and so on and so forth. Now let's talk about one of the last epidemiological, the last concept when it comes to calculating risk, and that is absolute risk. Absolute risk, from its name itself, is the risk of developing something over a specified period of time, and this time it is regardless of exposure or non-exposure. A simple example for this is if in 1 in 100 or even 1,000 chance of getting lung cancer, even if you have never smoked. So that is an example of a statement of an absolute risk. When someone tells you you have 1 in 100 chance of getting a lung cancer, even if you smoke or you smoke, whether you smoke or you don't smoke. So that is what we call the absolute risk. You can state it also 1 in 1,000 or 1 in 1,000,000, but again, it accounts for what is just simply the probability of developing a disease over a specified period, such as your lifetime, and whether you're exposed or non-exposed to a factor. Now, the last two common statistics that we report in epidemiology are prevalence and incidence. Prevalence and incidence are the different measures of disease occurrence. And when we talk about prevalence, simply we mean that how many number of people currently have the disease. And my mnemonics for this, in order to remember this clearly, is just to put what is the number of people who have new and old disease. So it's just old and new. In comparison, your incidence refers to the annual number of people who have a case of the condition. It's actually, and when we talk about annual number, that is new only. And so that is a very important concept that you need to associate with incidence, is that this is a report of new cases only of a disease or an illness. So when we say that diabetes can have a low annual incidence but high prevalence, that is simply because diabetes is a chronic condition and it lingers, and therefore it keeps on accumulating the number of people who have the disease. So you'll have a lot of diabetes cases, that what we call the old cases, and so you will have a high prevalence because diabetes is chronic. Whereas if you say the deaths from car accidents can have a very high annual incidence, but they may have low prevalence in 1 year, because the deaths from car accidents are acute conditions, and you start counting them from January to December, you may have low prevalence because there are basically car accidents. Deaths from car accidents are basically acute conditions, and they don't linger, and they don't keep adding up month by month by month by month. Okay. So those are the differences. Now, there are some problems with prevalence data that we need to remember. So prevalence, as I've mentioned, are those who currently have the disease, and sometimes it's really very hard to compare the estimates of prevalence, and there are many different methods of collecting the data that could also cause problems with prevalence. One of the limitations, I think, especially are your data coder, and if they don't code the data properly as well, and if the features or characteristics of the disease are not clearly stipulated, then there might be incorrect data entry as well. So, and the other problem with prevalence is especially in cancer cases. So cancer can go into remission, and when patients are in remission, are we supposed to still count them under the prevalence as something as old? And those are some of the things that have not been really ironed out. But I think in general, once the patient has cancer, despite the fact that they are in remission, they are counted as patients having cancer until they are actually dead, and then statistic changes and they're no longer part of the prevalence data. So that's one of the limitations about prevalence, because even though they're in remission, again, cancer patients are always counted as having cancer. What about incidence data? Well, we still have problems as well with incidence data. there are attempts. These are attempts to measure the number of people who become affected with a condition each year, and so we're talking about new cases. The limitation, of course, is that it only includes new cases, not ongoing treatment. What I like about incidence is that when you compare incidence data either month per month or year by year, depending on your variable of interest, incidence data definitely gets the attention of legislators and lawmakers and all your elected officials as well. Incidence data is very useful in tracking pandemics as well. Um, Sometimes, though, you again, that's what to say. You always look at your data with a grain of salt all the time. Incidence data could also have over-reporting problem, especially for vague diseases with vague signs and symptoms, missed categories, and so on and so forth. The other, I think, good example of problems with incidence data is the Ebola outbreak in Africa. There were so much underreporting because the locals were actually hiding patients who have been suspected to have Ebola because when the villagers found out that if you have signs and symptoms of Ebola, the Department of Health will take you to a makeshift hospital, and most of the time the patient actually died. So it was like 9 out of 10 who were brought to this makeshift hospital did not come out alive. So when the word spread out to the villagers that that's what the Department of Health is doing, once a person has signs and symptoms, they actually hide their loved ones because they don't want the Department of Health to take their loved ones away from them, and they would rather have them inside their house and die inside their house, and it actually propagates the transmission of the virus from one member to the next instead of isolating that person. So again, always look at your incidence data, but also analyze what is happening. You need to be aware of the whole situation. So that's it. I think that we are done with week 2. Any questions again, please email me. And I apologize for the typo. I am heading now to the airport pretty much very soon. And so, again, I think I apologize for those typo. Take care. And I'll be in touch with you again next week for the next, for week 3 slide sets.